Good afternoon. We're going to begin our discussion on posture and muscle imbalances. So these documents can be found in your Blackboard account under posture. So I'm going to just give the introduction here to posture and different postural types. And then we will be getting into how to test for flexibility or length of muscle. And then we will also review muscle strength. And so we're going to start with this particular document that again is on your Blackboard account under posture, the posture folder. And it's entitled Muscle Imbalance, Posture, and Postural Pain Syndromes. This information is coming from Florence Kendall, who is one of the pioneers of our profession. And she literally wrote the book on manual muscle testing and also has a textbook on the relationship between pain syndromes, and posture. So much of our information is coming from that source. And instead of having you purchase her hardback textbook, which is quite expensive, we have taken information from there and put it in our handouts here. So the first concept that we want to review is to prevent pain, there needs to be a balance of muscle pulls around the joint so that the joint rotates about that particular axis. And the basis of treatment is that without a balance of muscle, the joint axis will move incorrectly and thus cause more stress and wear and tear on the joints, which, according to Kendall, produced misalignment and pain. Now, as we look at the literature, we note that there are people who do have poor posture, but they are not experiencing pain. And so that's sort of where the theory falls out. But I think that you will find that a lot of our patients with back and neck pain or even thoracic pain or other areas of the body, when you test their muscles, you will find that there is an imbalance. And so I have found this information to be extremely helpful. Florence Kendall has since, she has since passed away, but I actually got the pleasure of attending one of her workshops. She and Shirley Sarman were at the Indiana APTA conference one year, and this really opened up a whole new world for me in physical therapy when I began to look at things this way. So I think this information will be very valuable to you. But as we've said before, muscles work in force couples. They don't really work independent of one another. They work to, together to form a motion. So they must be balanced to rotate around an axis correctly, or again, this could cause pain. So we have some examples here. Upper trap and lower trap. During upward rotation, if the lower trap is weak, the scapula will stay downwardly rotated, which could produce an impingement at the shoulder. And I think you will find that upper trap does tend to be extremely strong and lower trap tends to be extremely weak. Some other examples here, the TFL, the tensor fasciae lata with the gluteus maximus during hip abduction. During weight bearing, it could cause the hip to rotate in an unbalanced manner, which will misalign the knee and the ankle joint, and then therefore can create pain for the patient. Muscle length is also important. This is an area that we have not yet discussed, and so we are going to be getting into how do we know if a muscle is long enough or if it has enough flexibility. So muscles that are too long or too short can cause abnormal muscle motion and pain. So if muscles are habitually kept in a stretched position, they will grow more sarcomeres, and they cannot contract in that shortened range, and that produces what's called stretch weakness. So generally, if the muscle is lengthened or too long, it tends to be weak. Tight muscles tend to be overly strong. And so we want to look at the balance between the muscles on all sides of the joint and try to create balance of strength and length. So some examples here, if the muscles are too short, if you have short pectoralis and intercostals, which are the ones that are, intercostals are the ones that are attaching to the ribs. If those are too short, they can prevent the thoracic spine from extending, and we can get too much shoulder retraction. If the hip flexors are too short, this can cause anterior pelvic tilting in standing, and this produces a strain on the lumbar spine, because if the pelvis is in a habitual anterior tilt, then that is going to cause the lumbar spine will be in excessive extension. So therefore, the lumbar extensors will tend to be too short and tight. If the lumbar extensors are too short, they will cause, again, excessive lumbar extension, or also called a lordosis. And then we have what's happening on the other side. If the muscles are too long, for example, if the muscles on the back side of the thoracic area, the thoracic extensors, are too long, that's going to cause a humpback, or also called excessive kyphosis. If the abdominals on the anterior side of the trunk are too long, and again, if the muscle is too long, it's typically too weak. So if the abdominals, particularly the lower abdominals, are too long and weak, then that can cause excessive lumbar lordosis. And then there are some other examples here with the hip abductors. If they're too long on one side and too short on the other, then that can alter the position of the pelvis, which could create a scoliosis. If the upper traps are too long, that would mean that the shoulders, instead of looking like in a box fashion, there would actually be some depression going on there because the muscles are too long. Remember, the upper traps elevate the shoulder girdle, so if they are too long, the shoulders will be sitting a little bit lower, and this can put pressure through the thoracic outlet area and produce thoracic outlet syndrome. If your pectoralis minor is too tight and lower traps are too long, the scapula will stay downwardly tipped, and this can cause an impingement. So as a general rule, we need to strengthen, or we need to lengthen shortened muscles, or we need to stretch them, and then we need to strengthen. If things are too tight, we're going to lengthen them first or stretch them. And so that's what we're going to talk about with when we get into some of the Shirley Sarman exercises for postural correction. And the beauty of those is that you will be strengthening on one side of the joint while you're stretching on the other side of the joint. So you can hit posture with really minimal exercises because you're working both sides at the same time. For muscle recruitment, this is interesting because if any of us, you or your patients, have a muscle that is too strong, the central nervous system will incorrectly learn to use that muscle. And so it's kind of like the body takes the path of least resistance. And so therefore muscles that are weak will tend to stay weak and underused, and those that are tight, our bodies tend to recruit those muscle fibers over and over again, and those muscles actually become stronger. And so over time, the patient has learned to use only certain muscles that are strong. And so we're going to want to try to reverse that with our corrective exercises. And we have some more examples here, and there's lots of them. But with any of these things that are numbered 1, 2, 3, 4, basically the take-home point is that we are going to stretch what is shortened, and we are going to strengthen what is lengthened, or is not strong enough. So the principles of correction, again, we want muscle balance. We want to pay attention to the different postural types, and we're going to look at a lot of different examples and try to figure out what is causing the postural deficit and do some corrective exercises to help it. Okay, so let's first, before we go on with our lab here, I want to talk about the 4 different postural types that Florence Kendall coined. And she was really ahead of her time for a number of reasons, but one of the big things here was that she was actually categorizing patient types, and that is a way of, you know, an efficient way of diagnosing someone, if you will, with a physical therapy diagnosis, because if they fit into a certain category, then in essence, they should respond to, you know, a certain type of treatment. So the first one that she named was just the ideal posture. And so we're going to be looking at each other's posture after I finish this, and then you guys can analyze each other's posture. But what you want to do is you want to look at the posture from the sagittal view, which is the side view, and you're going to look at this plumb line. And we have some plumb lines in the lab. We'll get them out, and you guys can position according to the plumb line. And then I want you to identify what postural type you and your lab partners are. But for us to have ideal posture, and if with ideal we mean that there should be a balance of muscle on all sides. So that means that they should have normal strength and they should have normal length of all of their muscles. And we do find people who have ideal posture, but it's pretty rare, especially in the clinic, but we will probably have some in the lab potentially who have ideal posture. So what you want to do is you set up a grid, and then you hang a plumb line. Now you've got to know where to start the plumb line. So you start it looking at the ankle. So it says just anterior to the lateral malleolus. And so when you're looking and you're lining yourselves up, then you just want that plumb line a little bit in front of the lateral malleolus, and then you're going to see where it falls all the way up the chain. So with that ideal posture, the plumb line should fall just anterior to the knee axis. It almost looks like it goes midway through, but by definition, it should be a little bit anterior. The plumb line should fall slightly posterior to the hip joint. And so when you're doing this with each other, you can locate your greater trochanter. And while your lab partner is evaluating you, they can tell if the plumb line is in front or behind the greater trochanter. The plumb line should fall through the bodies of the lumbar vertebrae. And again, it should almost separate the front half from the back half, almost directly in line. It should divide the thorax again in half. And then it should come, the plumb line should come through the acromion, so you can palpate that. And if you were doing it in the clinic, you could actually put little, pin marks on those body parts so that you can see them in relationship to the plumb line. The plumb line is really going to show up a lot of deficits or postural issues. And then the plumb line should fall through the cervical vertebrae and it should go through the earlobe. So that was the first type, was ideal. Then Florence Kendall named kypholordosis as the second postural type. And this is characterized by excessive lumbar lordosis and thoracic kyphosis. And I think if you're just looking at people in the community and just watching the way they stand, this is a very typical posture, and many of our patients also exhibit this posture. And so again, you're going to line the person up and just put the plumb line slightly anterior to the lateral malleolus, and then you're going to follow up the chain. So just by having the patient stand to the side and looking at them, you can really see this exaggeration of curves. So if you see that excessive thoracic kyphosis followed by excessive lumbar lordosis, you're going to name that as the kypholordotic posture. So because there is excessive lumbar lordosis here, this correlates with excessive lumbar extension. Lumbar extension will always be producing an anterior pelvic tilt, which will also always put the hips in flexion. So if you look at what the pelvis is doing, if it's an anterior pelvic tilt, you can remember that that's going to create lumbar extension, and then the hips are going to go in the opposite direction. If the hips were also going in extension, well, then the person would fall backward. So we have to have a balance here for the feet to hit the floor and the patient to be able, or any of us to be able to stand upright. So in this case, the thoracic extensors, so here the erector spinae on the back side of the spine, those are going to be too long, and therefore they are going to be weak. And so what we're going to do is we're going to come back and we're going to say, okay, how do I know if this is long and or if this is weak? So that's where we're going to get into the length test and the strength test. So here, the thoracic extensors are too long. The lumbar extensors are going to be short. They're short and tight. Now, on the opposite side of the curve, we have the abdominals. This is an excellent example of the abdominals being too long. And in fact, when abdominals are long and weak like that, they are going to not be able to control the pelvic tilt. And so there's going to be a very specific way that we can test, particularly the lower abdominals. In this case, the mid-trap and the rhomboids, again, those are on the posterior side of the scapula. They will be too long and therefore too weak. The iliopsoas, because the hips are in flexion, the iliopsoas is going to be short. Now remember, the iliopsoas only crosses the hip joint. It does cross the trunk, but really it's the one joint hip flexor. Then again, the lumbar paraspinals, the lumbar extensors are too short, therefore they are going to tend to be strong. We need to go in and pick up how do we know that those are strong, and we'll talk about manual muscle testing those. The pectoralis are going to be too weak. So if you see these forward shoulders is really what's happening here. Forward shoulders, sort of that rounded neck position. When the shoulders are too far forward, the pecs are going to be too short. Again, how are we gonna, we need to come back and say, this is how we're gonna test for length. You already know how to test manual muscle test for that. And then the intercostals can be too short. So anytime you have excessive kyphosis, the ribs, the intercostals, that can sort of crunch down the rib cage and can, you know, potentially create respiratory problems. Usually with a posture like that, unless it's excessive, you're not going to see changes in the respiratory status, but you could. Now, sway back is the next postural type that, again, Florence Kendall coined. This is kyphosis with the thoracic spine swayed backward and the pelvis swayed forward. So the difference here, and again, we always do sort of a compare and a contrast, because this does look similar to the kypholordosis, but the major difference here is that the pelvis is tilted posteriorly. With the kypholordosis, it was tilted anteriorly. And so whenever the pelvis is tilted posteriorly, that is going to equate with lumbar flexion. And so you do see sort of a flattening of the natural lumbar curve back here. And that's one way that you can tell the difference. Now, because the pelvis is swaying posterior into a posterior pelvic tilt, creating lumbar flexion, the hips will do the opposite. They have to. So they will be in a position of extension. And I know this doesn't look much like the traditional hip extension that we're used to talking about, but that is what is happening at the joint, within the joint surfaces themselves. And so I always remember that posterior pelvic tilt produces lumbar flexion. The hips have to do the opposite. If the hips were also flexing, then the person would fall forward. So the hips will do just the opposite of the lumbar spine. Tendency toward the spine using spine instead of hip motion in walking and running. Generally speaking, we don't want the tail wagging the dog. We want the dog wagging the tail. And so the more proximal segments of the spine being the most proximal segment, it should be the most stable. And what we're saying here is that there is a distal joint, i.e. the hip joint, that is creating too much, or it's too tight and the spine is moving too much. So generally speaking, again, if you think about the dog wagging the tail, you can remember that. The dog's spine will stay still while the tail wags. The more distal end will wag. It should not be the other way around. So in this particular postural type, again, we've got the kyphosis. So the thoracic extensors, or the paraspinals, also called the erector spinae more specifically, are going to be too long. And when we get to manual muscle testing, they will likely test weak. Now, the lumbar paraspinals, those have gone from a position of tightening to now they are lengthening, because they're lengthening over that posterior pelvic tilt. The lower abdominals are long. The iliopsoas is long because the hip flexors, or the hips, are in flexion. So the iliopsoas is going to have to stretch over that extended hip. TFL, tensor fasciae lata, and rectus may be short. We're going to learn how to test if these muscles are short or tight or lack flexibility. So kind of hang on to that, but we will get to that. Gluteus maximus tends to be atrophied. And so these guys are going to have what I might call like a flat butt kind of posture, not a nice round rump here, it just kind of looks flat. Again, you should be, you can think to yourself, okay, now how do I test, manual muscle test, how would I test for the gluteus maximus? And then the hamstrings are too short. So we know how to test for hamstring strength. We do not yet specifically know how to test for hamstring length, but we will get to that. And so we're going to bring all of this full circle. This is one reason that we had you learn so many different muscles and their actions and how to test their strength. The last posture that Kendall categorized was called a flat back. And here you see that there is a flattening. Again, we're going to line the patient up against the plumb line, with the plumb line just anterior to the lateral mal, and we're going to see how it falls up the chain. And so just on gross examination of the curves, I noticed that there's not a nice balance of curves. These definitely look flattened. It really does even look like there's a little bit maybe of an excessive kyphosis, not much, but look how flat this low back is. And so that's why it's named that. So both of the curves are really flattened. Oftentimes this is accompanied by a forward head. So in this case, the iliopsoas now is going to potentially be long and weak. That is because since there is a lack of lumbar lordosis here, the pelvis is in a posterior pelvic tilt. So now we have two postures that are characterized by posterior pelvic tilt, which are sway back and flat back. Kypholordosis is the only one of the four that is characterized by an anterior pelvic tilt. And so that's going to be very important, because then you're going to know what the hips are doing. In this case, because there is a flattening of the curve, the abdominals tend to be strong. The upper abs and the lower abs tend to be strong. We need to come back and say, okay, how do we test for that? And we will. You see here again the forward head posture. And so one of the corrective exercises for that is just to do that nice chin tuck that you learned during the McKenzie segments that we mentioned. So some of these you already know how to correct, but we're going to bring it full circle and put it together so that you kind of have it in a nice package. Now, because there's an excessive forward head, that cervical spine is going to have a little bit too much lordosis, and it's going to look like it's extending. The upper thoracic is generally flat or a little bit flexed. The lumbar spine is straight. The hips are extended. The knees can be hyperextended, and we are seeing that here. And it looks like the foot is in a little bit of plantar flexion. So as you are taking notes, if you could also add out here to the side, the pelvis is in a posterior pelvic tilt in this particular postural type, which I think will be important for you to remember as we progress on here. So then we can look at, there will be, Kendall identified what's called a handedness pattern. So depending on what side of your body that you're dominant on for handwriting, there can be some postural changes just simply related to that. Over the years, as we've looked at, you know, so many different students' postures, and we'll have you document, you know, what postural type you are. If there was any discrepancy on short and long, I think it was the handedness pattern. Some people will have a pelvis that's a little bit higher. I mean, if you look in picture A, the pelvis is higher on this side, on the right side, and the shoulder girdle is depressed. You know, that doesn't always happen. Sometimes with the handedness pattern, the shoulder girdle will be a little bit elevated on that side. But that would be something that you would want to note. It's not uncommon to see asymmetries. Now we've moved from the sagittal plane to the frontal plane here. So we're looking at the person from the back. So you'll want to notice that. And in this picture A, you see that this inferior angle is a little bit lower than this one. This iliac crest on the right is lower than on the left, and so on. So the handedness pattern can change the position of the pelvis and the spine, but as far as the general rule, as the way Kendall describes it, just in my personal background, it's not been quite as accurate as the other four postural types. And then we are going to look at other postural alignments. So once I finish this particular lecture, then we're going to break out and we should look at each other's posture from the sagittal view or looking at them from the lateral side. We also want to look at them from the posterior side and the anterior side. And we are going to be looking for asymmetries and or other types of maybe what we would call deformities. I mean, they're not really, you guys aren't going to have deformities necessarily. In the clinic, you'll find deformities such as hallux valgus. This means that the great toe is in a position of valgus, and that can create like a bunion over that particular area of the foot. Hammer toes would be excessive flexion. So there's tight intrinsics of those toe flexors. You're going to look for foot pronation, which if you're a pronator, you're going to be bearing weight on the medial side of your arch. This is at the subtalar joint. Remember, pronation and supination of the foot occur at the subtalar joint. The calcaneus will be an abduction. If you have foot pronation, that can also be labeled pes planus or a flat foot. So the navicular tuberosity, remember that's on the medial side of the foot. If you're in pronation, you're going to be bearing more weight on that navicular perhaps. You're going to have lower longitudinal arches, or also called flat feet. You can also tell if you're a pronator or supinator just by picking up your tennis shoe or whatever shoe that you more commonly wear And if it's more worn on the inside part of the heel, if you're looking at the back of it at the heels, if it's worn on the medial side, you're going to be a pronator. If it's more worn on the lateral side, then you're a supinator. So we're going to look at the feet. All of these things would be happening as we're looking at, the person probably from an anterior view. So as you're looking at each other from the anterior view, look at the feet. Do you have pronation? Do you have supination? And then as part of your postural analysis with each other, I want you to write down what it is that you're finding, because we're going to come back and we're going to test some things on length and strength. So do you or your partner have pronated feet? Do you have supinated feet? And then go up the chain. Do you notice genu valgum, which are knock knees? Do you notice sort of a bow-legged position, which would indicate genu varum? Are the legs or the hips tend to be laterally rotated with the feet turned out? Do they tend to be medially rotated? That would be the squinting patella that we looked at last time. And then from the side, do they have genu recurvatum, which is excessive knee hyperextension? Do they have a little bit of flexion at the knee? You would have to note that from the lateral or the sagittal view. And then you can look at, the different positions of the scapula. Are the scapula, you or your lab partners, are they abducted and lifted, abducted and elevated? Are they elevated and adducted, kind of like a military posture? Are they depressed and abducted? Are they winging? You're going to notice all of those. Any type of abnormal posture at the scapula is going to indicate a definite muscle problem. So here are some other things to look at in terms of the knees. You don't want the person to stand a certain way. You just really want to look at their resting position and standing, and then you are going to be documenting what you're finding from the sagittal view, the anterior view, and the posterior view, which of course would be occurring in the frontal plane. So I'm going to stop there. I think we have pictures of these with the good and the examples of good and not so good posture. So let's take a look at those in lab, and then we will move on to the doing part, which is learning how to test flexibility for all of these things.